Hi, everybody. Welcome to this a new webinar, which is part of the special series prepared by the International Academy for Clinical Hematology and dedicated to some important topics related to the COVID-19 pandemic emergency. And for this special webinar today, my guest is Professor Naveen Pemmaraju, who is an associate professor at MD Anderson Cancer Center in Houston in the US. Beside being a friend, Naveen is a top expert in the field of leukemia, especially myeloproliferative neoplasm. And you may remember not long time ago, he is the guy who published the New England Journal of Medicine paper about the first approved therapy for plasmacytoid dendritic cell neoplasm. So it's a great pleasure having Naveen with us today, especially that he has been on service, on the leukemia service over the last couple of weeks at MD Anderson. And our topic today is about the challenges and options that we have when treating acute leukemia during this period. And I'm sure you are all familiar now with the structure of these webinars. So we don't have formal slides, simply a few questions to structure the discussion. And so Naveen, welcome and thank you for dedicating some time to us despite your very busy schedule and being on service. So I hope you are well and safe. So my first question to you is about the general measures one needs to take when managing acute leukemia patient, whether AML or ALL. I believe it's true also for MDS, MPNs, during this COVID-19 pandemic. And I would like, we'll go later into the treatment approaches, but the general measures that you would recommend or you have applied. So I know there's no evidence-based data there, and all of this is empirical and based on common sense, and things that are true today may not be true tomorrow. So this is a very important disclaimer also to all of us. And we need to be very humble and modest because even the top expert in COVID-19 these days has only 3 or 4 months training, I would say.
That's right.
Naveen, what are your thoughts? What have you been doing over the last few weeks?
Right. Well, thank you for having me, Professor Modi. It's always a great honor, and really all the conferences you put on, both in live person and now here over the internet, are being viewed by many hundreds, if not thousands of people in our field. So thank you for spreading workable information to people who need it the most. This first question is important. Not only I'm going to give you some expert consensus, because as you said, we don't have much data in this rapidly evolving era, but I've also been on the front lines for the last several weeks. And I can tell you that there are some things that hospitals, big and small, European, Asian, American, wherever you are, can implement rapidly. First, for the general screening of any patient with acute leukemia, I and my colleagues are recommending, Mohammed, if it's available, to go ahead and do a COVID-19 testing on patients, the asymptomatic patient who's about to start induction or intensive chemotherapy. That alone, we believe, is in fact a qualification for the study. A nasal swab by a team that's dedicated and trained, that they themselves, right, the healthcare workers need to be safe. I think it's very important. The second aspect, not all hospitals may have resources to do this, but I think some baseline chest imaging, you and I have been doing that for years in many of our patients, at least a simple chest x-ray, But I and others, if resources are available, are advocating even for more chest imaging, possibly even a dry or non-contrast chest CT at baseline, similar to what you and I have been doing for CAR T patients or other therapies that are known to cause pulmonary side effects. So I would say the minimum is COVID-19 viral swab testing and some baseline chest imaging, even including a chest CT. There is a third thing I think is important, which is as these patients are being screened and put into the hospital, although it's challenging for the patients, I think restricting the visitors to 0 family members, or in the very, very special cases, whatever those are, to decrease the amount of people that are actually in the hospital, both for the patients, but also for us, the healthcare workers. I know this causes some grief and despair, Mohammed, but overall this has been working well, and to incorporate the family members through telemedicine, virtual visits on the rounds after, even if it includes technologies such as what we're using here, or iPhone or Zoom. So I'd like to turn it back to you. Those are some of the simple things I think we can do for every patient, acute leukemia in the COVID era.
No, I think we're perfectly on the same page, and actually these are indeed the recommendations that were put by different experts and different colleagues. So we're talking about PCR screening, just to make it clear. But I agree with you that in our own department, we've seen half a dozen of patients who had the typical COVID-19 lung infection while the PCR was negative. And actually the CT scan gave a clue and allowed to manage these patients. So definitely it's an important message, because we do know very well that there are negative PCRs, I mean false negative PCRs, and it needs to be repeated. So being able to combine both is absolutely important. Obviously, you alluded to the fact that we need to limit the visits, the circulation, in order to avoid or minimize the circulation of the virus. And this is in the interest of our patient, because I think we didn't mention it, but this is now becoming very clear to the community that our patients are part of this vulnerable group of patients, I would say, where the risk of COVID-19 are likely more important than in healthy individual getting this infection. So let me now move to some practical scenarios, Naveen. Let's imagine tomorrow or today, when you're gonna start your service, you have a new young patient, fit patient, and then we'll handle the unfit in a few minutes. 45 years old, fit, suspicion of acute myeloid leukemia. What is your, I would say, let's call it SOP during this COVID-19 period, please?
Right, and as you alluded to earlier, and as you know at your own hospital system, this is changing daily and rapidly, so we'll put that caveat out there. Right now, what we've been doing in this month of April, acute leukemia is very important. This is not a situation, as you and I know, and many of our viewers, that in many cases can be delayed, particularly the young patient AML curative intent. You check the COVID test on everyone. Let's take the example that someone's COVID negative, but still we need to be mindful of the hospital system, hospital resources, risk of superinfection. So COVID or not, how about bacterial, fungal, and viral, what we're already worried about? How about the amount and frequency of visits for the patient once they get to the outpatient? And then finally, the risk of subsequently developing COVID, my goodness, even after negative during the induction. In this situation, it's an abundance of caution. If you have a young curable patient, you can still reasonably see a situation for moderate to intensive therapy, but it has to be in the hospital setting, COVID negative, frequent testing, or at least chest imaging, as you mentioned nicely, to protect against false negatives, and then judicious use of prophylactic antibiotics in these patients to prevent against superimposed infection. There's a second thread that's going. We've already seen the explosion nicely of oral targeted therapies and hypomethylator agents. You and I have been using them for years now in the older patient population. Prior to COVID, there was already a movement in the clinical trial space to use some of these agents, venetoclax, hypomethylator agents, in the younger or moderate fit patients. And so I think what you're going to see now over the coming year, 2020 to 2021, is an acceleration of investigation formally, but also off-label real-world investigation of lower and medium intensity therapies into the younger patients. We're not advocating that on this webcast. We're not saying we have all of the data. But if you have a COVID-19 positive patient that cannot be delayed with therapy and you cannot give the intensive regimens that are available, this is the time that you, me, our other colleagues and thought leaders are starting to think about moving moderate intensity therapy into the frontline setting. So I want to turn it back to you. I'm actually curious to hear your thoughts, but this is one of the hottest areas in our field.
Okay, so my understanding and what we're currently doing, and again, I think we are on the same line.
Yeah.
So in a young and fit AML patient, COVID-19 negative, let's start with this, we should not delay treatment. I think this is important because in other diseases, for instance, we may be able to postpone or delay for a couple of weeks to gain time. Here in this case, I think I would say it should be treatment as usual.
That's right.
So plan A would be in a fit patient induction. Let's start with a traditional 3+7. And plan B, if for some reason we cannot or we do not wish to use an intensive chemotherapy, intensive induction, then we can move to these oral options, as you have mentioned, or to the subcute like hypomethylating agent or venetoclax or combinations, of course, and so on. So that's the induction. Assuming now we have a patient who received his induction, her induction, for instance, and what about consolidation?
Yes.
Business as usual, or we do have options?
Some hybrid there, right? I think we have some options. So let's take the young fit patient in the community setting, 7+3, or in the academic centers, 3 and 4 drug induction regimens. I think you're right. The consolidation, what I'm finding are two challenges. Now the patient has likely moved from the inpatient setting to the outpatient. The question now is, these cannot be done by telemedicine visits, right? So these are patients who acutely need to be seen, not only for the high-dose Ara-C-based chemo consolidations, but as you and I know, for evaluation for the blood, transfusions, maybe antibiotics in the outpatient setting. I think that the combination of social distancing, restricting the visitors, and telemedicine visits for the chronic patients, as we'll talk about later, will then allow us to have the space for you and I and others to treat these acute patients. So I actually do advocate, as long as you're COVID negative and you've checked it, in the absence of infection or other reason, let's continue to go for goals of care, curative intent for AML patients under a certain age. So that I think that's an important point that you bring up.
And I believe this is particularly true if we are dealing with the adverse cytogenetic risk and bad prognosis molecular biology, because obviously if there is a real chance of a curative option like allogeneic stem cell transplantation in these patients, we should not treat these patients.
Well said.
So let me consider now the scenario of an unfit patient coming frontline. So we're talking now, let's say, about a gentleman who's 75 years old, newly diagnosed AML. What is your attitude towards this patient after, the usual screening, CT scan that we already discussed?
That's the hottest, most important area, and I think a lot of our colleagues are asking that as well. I think in the unfit patient during the COVID era, age notwithstanding, but based on performance status comorbidities, if intensive chemotherapy is contraindicated or may cause more problems than harm, these are the kind of patients, case by case basis, we're thinking about the medium intensity regimen. So the HMA plus venetoclax, so hypomethylator, decitabine, or azacitidine in particular, with venetoclax is something that's being thought about. We were already thinking about that pre-COVID. If it is effective in the older patients, can we now move this into the younger unfit patient? A second class, Mohammed, is also the importance of genomic testing. I know a lot of hospital systems right now are stressed to the brink, so we're not talking about every system, but if your hospital system can allow, the genomic molecular testing for AML is becoming more important every year. Let's suppose you find someone with a FLT3 mutation or an IDH1 or 2 mutation. Even in the absence of clinical trial, there may be oral targeted therapies that your patient can benefit from in combination with others. If you have access to clinical trials still, again, we know a lot of our colleagues may not at this time, some of the other more advanced molecular mutations such as TP53 and others, and you mentioned these high-risk cytogenetic subgroups, there may be some chance for personalization, stratification, either on or off clinical trial to get patients to other therapies outside of traditional cytotoxic. And I have to say, this time is important. We have to be judicious with resources, but there are some patients who are potentially still curative in high-risk situations that we have to make sure that we don't undertreat, as you just said, and still deliver curative therapy. That's the challenge we have in 2020 today.
Now, I think you're alluding to an important point, and we didn't mention this, but for the sake of clarity and comprehensiveness, we need to mention this, that despite the COVID-19 extraordinary circumstances, it is still highly recommended unless there is something really special or unusual, that cytogenetics and molecular biology data should be awaited before deciding on the full treatment package. They are still mandatory, and at the time we are having this webinar, it looks like that the news from across the globe are rather showing some improvement, although we need to be extremely cautious about the so-called second wave of the pandemic. But definitely cytogenetics, molecular biology are crucial. So I think we had a good picture about AML. What's the situation in ALL, Naveen? And again, we'll divide it, I know things are not always black and white, but for the sake of a 30 or 40 minutes webinar, we need to make it simple, I would say. So young and fit ALL patient, what is your current approach?
So young and fit, this is a very important, dear to my heart question, because again, I really appreciate the way you framed it, curability versus other states. So in terms of goals of care, these are still among our most curable patients that we have. Our colleagues know that in the pediatric space, this has become a very curable disease, but for us in the younger adult, there is still not 100% cure rate. But among the patients, we're able to give intensive or at least intensive type therapies, such as the hyper-CVAD regimen pioneered at our institution by Dr. Kantarjan, taking these pediatric high-intensity regimens that have been inspired there, adapting it for adults. In our hands, as you know, we've had very high cure rates. In this era of COVID-19, we have to recognize that these myelosuppressive intensive regimens may be very difficult, again, even in the COVID-negative patient population because of frequent visits for blood transfusions, high infection rates. So one consideration has been the modification of these backbone therapies. Say the hyper-CVAD, Mohammed, as you know, we've pioneered the mini CVD regimen. So maybe removing the anthracycline, but instead adding the newer class of agents in sequential therapy. And so what that therapy looks like, if your hospital has access and resources, is do the mini CVD, less cycles, but then add in the monoclonal antibodies, the CD19 directed, such as the blinatumomab, the CD22 inotuzumab. If you have access to clinical trial, fine, but if not, these are at least FDA-approved therapies, with the goal being two things. One, reducing the overall myelosuppression and overall risk of infections. And two, we're actually showing in our early data increased curability, increased remission rates with less cytotoxic chemo. So I would say in the younger fit patient, the concept here is, can you introduce the monoclonal antibodies sooner and earlier as part of a total therapy program, decreasing cytotoxic chemotherapy, less myelosuppression, less infections? This may be a curable approach and may even obviate the need for stem cell transplants in many of these patients. Mohammed?
So what I can see and hear from what you're saying is maybe this COVID-19 period may represent actually the right or a good opportunity to use some regimens which are not considered as classical or standard regimens. And you namely alluded to the combination of inotuzumab and blinatumomab pioneered by Dr. Kantarjian, especially in the elderly unfit ALL patient. And I agree, I mean, the results are really impressive, although the follow-up is still relatively short, but actually combining these drugs frontline is extremely appealing and attractive and yielding some important results. So we may wish, resources allowing and depending on the environment, that these are valid options, and why not, you know, moving into the younger population.
Right.
No, this is extremely interesting, and I'm sure many colleagues and many experts in the field are already considering this kind of combinations. Let me go back a little bit to the so-called, let's say, classical standard regimen. And I'd like to have a focus on steroids, because we know very well that in ALL, steroids are really a backbone, an important component. But we also know from the available literature, from the experience we have from our ICU guys and so on, that steroids are also a major risk factor for the COVID-19 infection. And I would say not only risk factor, but it's a sort of an aggravating factor. So are there any tools or tricks trying to minimize steroids in these patients?
Yeah, this is something we discussed recently as part of our group, and you're right. I really appreciate the way you framed it. Because we still believe steroids, at least dexamethasone and the hyper-CVAD regimen and other regimens, prednisone and CHOP and others, I think it's important to still try to incorporate steroids. But one trick we've done is, instead of using 40 milligrams of dex, maybe use half the dose, so 20 milligrams, but still give it in the days 1 through 4 and then in the day 11. So I think you're right. I think a strategy of reducing the dose of steroids, still delivering the anti-neoplastic therapy, but reducing the immunosuppressive, that's a strategy that we and others have used successfully.
Excellent. So what is your, I mean, you mentioned this, and we know that it's not black and white, it's a continuum, you know. Age by itself is not the only factor to consider, but also comorbidities. Beside, you know, the combination of the novel antibodies, any recommended regimen in elderly ALL, standard regimen?
Yeah, there's been a couple of breakthroughs to share. So I think one is in the Philadelphia positive elderly ALL. This is pioneered by actually you and others in France and Europe have really led the way on this, which is this so-called monoclonal antibody plus TKI approach. So the latest being the blinatumomab ponatinib. I've been very impressed, at least with the early short-term data. The concept here is, can you offer a chemo-free approach, Mohammed, to the older patient with ALL, either, especially with Philadelphia positive? So that is something that is so encouraging that may even need to be explored into even younger ages. In the non-Philadelphia patient, I guess, again, the same concept. Can you give the intensive regimens but modify them? So hyper-CVAD modified down to the mini CVD. And again, we've had quite a bit of success early on with doing, say, mini CVD plus blinatumomab, or mini CVD plus inotuzumab. Also, lowering the doses of the inotuzumab has helped in terms of the VOD, adding on the medicine ursodiol And then the blinatumomab here in the US, Mohammed, there is a movement towards changing the bag every 7 days rather than every 48 hours, which decreases hospital resources, visits, exposure to the virus. I think these are some of the tools and tricks, and I like what you said. Necessity is the mother of invention. In other words, these are things we were doing pre-COVID that have accelerated our thinking and may actually benefit our patients post this first COVID era.
Wonderful. I think this is extremely useful, and I believe our goal, of course, is to protect our patient against COVID-19 infection. But maybe I'm repeating myself because I've been repeating this through several webinars, is that we would like also to continue to deliver a state-of-the-art therapy,
Right.
curative therapy, whenever possible to our patient, because we don't want, we do not accept any loss of opportunity, because leukemia by itself is a terrible and potentially fatal condition, disease. So we don't want to have this double-edged sword
Right.
on our patient. So
Brilliant.
now let me move to MDS and MPNs. Obviously, the title is acute leukemia, but I believe most of our colleagues are familiar with the fact that we usually put this under the umbrella of acute leukemia. Any special thoughts? We will not go through all the details of every single entity, but just again, general guidelines or your feeling from what you've seen in the clinic during this period.
Yeah, a couple of pearls that have emerged that may not have come up just a month ago. I think a couple of things that are important for you and me and our colleagues. One is this concept of, can we appropriately delay therapy in the setting of a pandemic? And these are the subgroup of patients that there are some that we know. So take an earlier stage patient. Can you employ active observation, watch and wait for a few weeks, even if it's 2 to 3, 4 weeks? And we know there's some groups of low risk patients in both MF and MDS that can occur. So can you do either growth factor support, watchful waiting? That's actually important, and delaying by 1 month, particularly for an out of town, out of state patient, can make all the difference. A second concept is the increased importance, you and I have talked about this over the years, of coordinating with the local treating physician. So you and I are at our academic center in the big city, but if the patient lives 3, 4, 5 hours away, before COVID, no problem, drive, stay here for 3 days, let's get treated, hotel room. These things are not available. Travel, hotel, restaurants. Can you now employ telemedicine and actual real guidance at the local level, visual, phone reminders, coordinating with the local doctor? Yes, it may add some time, but this may be a chance to deliver local care. And finally, there is a thread ongoing now about the oral daily therapies that a lot of our patients have to take. For example, myelofibrosis. Let's take the example of JAK inhibitors. Interestingly, there's data and supposition, Mohammed, on both sides, that JAK inhibitors by definition are immunosuppressive, and they can increase the chance for viral and opportunistic infections, fine. But on the other hand, there's a phase 3 trial that was just launched by our colleagues and Insight to possibly treat some of the side effects and complications of COVID, particularly the CRS. So I think really advocating for, if you're already on a therapy, stay on it as long as you're talking to your doctor and modifying it, not abruptly stopping randomly. And then this concept of the double-edged sword that you mentioned, that some of these therapies, BTK inhibitors for CLL, JAK inhibitors for myelofibrosis, can both contribute to, but then possibly treat this novel coronavirus. I don't know what your thoughts are on that, but that's kind of the questions we're getting here in the clinic.
This is interesting. I didn't think about mentioning this, but actually we've seen, I think a few days ago, a pre-published paper in Blood about the potential protective effect of ibrutinib in those patients treated for Waldenstrom disease, and that is from the Dana-Farber groups. And obviously you mentioned the issue of ruxolitinib, JAK2 inhibitor, and you're right. I mean, there is a phase 3, but there are several other case reports suggesting, well, why not using ruxolitinib during the inflammatory phase? But I
Right.
think the key message, and this is very important for the patient, for the families, caregivers who are watching or listening, please do not stop or modify your ongoing treatment without discussing or consulting with your physician,
Yes. Well said.
because this can do more harm than the risk of COVID in some cases. But definitely, I think we are also in agreement that in MDS, especially low risk MDS, but also MPNs, I mean, we've been transplanting a lot of myelofibrosis
Right.
cases over the last 2 or 3 years because this remains the only curative treatment option. And actually, this is a typical situation where I believe you can delay the transplant procedure by 3, 4, 5 weeks without having a
Right.
negative impact on the survival of the patient.
Absolutely. And I think this concept of introducing more immunosuppression and taking up a hospital bed, this is something that we'll think about before and after this pandemic. And the transplantation of chronic diseases, not the acute, but the chronic, is something I think we'll reevaluate, probably for the betterment of everybody.
Yeah, well, that brings me to the last question of our discussion about the allogeneic stem cell transplant indications. And there have been a lot of webinars by different societies from Europe, EBMT, but also the ASBMT or former ASBMT, American Society of Cellular Therapy, yeah,
Right.
ASCTC. Now we need to become familiar now with all the new names because everybody's adding cellular therapy to their
That's right.
names. So just to make a long story short, I think the in acute leukemia like AML, which I would call the urgent, so-called urgent
Right.
indications, it should continue, and we've been continuing this transplant activity. On the other hand, when it comes to the chronic diseases like myelofibrosis or MDS, I think there is no harm in delaying or postponing in order to make things easier, smoother, because circulation is limited, the confinement is there, unrelated graft. Also, I think all donor registries have done a fantastic, wonderful job in securing
Yes.
grafts to everybody, everywhere. Still, it has been extremely challenging.
Right.
Here, maybe I'd like to ask you a very specific question because I'm sure some colleagues may have been faced with this. Assuming we have an indication for transplant in an AML patient, let's say high-risk patient, so the indication is there, no question. And if this patient is MRD negative, does this put you in a comfortable situation to say, okay, especially if the patient, is not willing, because we've seen also patient, it's not only about the physician, but we've seen patient telling, hey, is it really mandatory? I mean, I have in mind last week a patient who called, he was about to enter into consolidation, and he said, can't we delay this a little bit? I'm worried. It's not about the hospital, but, I'll take, the taxi, then I'll meet with this, blah, blah, blah. And I thought, well, if this patient is MRD negative, well, why not? Maybe it can give us some time to rethink. What do you think?
Right. Yeah, I think this era, again, Mohammed, this has been very intellectually stimulating to me as well as I approach my research pre and post the COVID era. Yeah, you hit on a very important point. For our viewers, just to remind them, in ALL, in acute lymphoblastic leukemia, we have been using the MRD for many years now as a very solid, bona fide treatment decision landmark. And for you and me, some of our colleagues, we have been using in AML the MRD status, but although we have to all admit out loud that it may not be quite there yet in terms of the data, but yes, I am using the AML MRD if I can to help at least as part of the treatment decision. You bring up a good point. There may be a subset. There may be, in fact, a subset of AML that even with some moderate risk features, perhaps we have cured them with chemotherapy alone, and we are starting to see that. It brings up a question of if a patient cannot go to transplant or it's not available, but you still have a 50% higher worry for relapse, this is actually a great time to talk about some innovations such as maintenance therapy. We have never historically done this in AML. Some scattered data, some from our institution showing possibly hypomethylator post-transplant or even extended AML maintenance, but most of the maintenance studies that you and I know from Europe and America have been negative until the latest data from ASH this year when our colleague Andrew Way presented the Quasar data for this oral azacitidine. Keep in mind at the time of this recording, not yet FDA approved, but being considered. And I think this is brilliant what you're asking. Can this be now a time where we can put people on oral, easier to tolerate, easier to take, not requiring hospital visit maintenance to not only extend the remission, but improve the overall survival and possibly obviate the need for transplant in some of these patients? So what an amazing question. I would ask all of our colleagues across the world to really accelerate the research into this oral and other maintenance therapies that may prolong, put off, or even completely obviate the need for a stem cell transplant in some of these patients. Mohammed?
Well, actually, I love your optimism, Naveen, because this is this positive way of thinking is crucial.
Right.
And actually, this is how I hope we will be able to transform a crisis, a disaster, because we have a lot of thoughts to all the victims of this COVID-19 worldwide, not only those who died, but all their families and close friends, but also those who, despite being cured, but suffered and spent a lot of time in ICU. So we think about everybody, but still, we would like to be positive, and maybe something better will come out of this crisis. And here we are debating that maybe in the field of acute leukemia, we will have new ideas, and we're having new ways of treating, new combinations, new approaches. Probably it has been already on the way, but there is an acceleration.
That's it.
So that was really a fantastic discussion. I really enjoyed it. I learned a lot, as always, from you, Naveen. And I think I'd like to thank you a lot for your time. Maybe we still have some time, and we'll take some questions from our audience. Hundreds of people worldwide, more than 100 different countries. It's quite amazing. So if you allow me, and if you can stay with us, then we'll take a few questions. So please use the chatter, guys, and write your questions. Obviously, we won't be able, because every time we have 100+ questions from everywhere. So I'll try to group them, and then we'll have like 5 to 10 minutes discussion. So thank you very much, and we'll wait for the questions. Thank you.
Thank you, Mohammed. Thanks for having me. What a stimulating discussion, and a lot of hope and optimism in these uncertain and tough times because of you and your team. And thanks for spreading information and hope in these otherwise difficult times for people. Thank you.
Okay, so now up to you guys. Send your questions.